Kia ora everyone. Welcome to this Goodfellow webinar on breast health and midlife, risk assessment and cancer detection. This webinar is kindly supported by Alivia Hospitals. My name is Dr. Helen Fulcher. I'm your moderator for this evening, and we have three amazing speakers coming to speak tonight on their various topics. They all work within a comprehensive interdisciplinary team under the setting of Alivia Breast Care. We've got Dr. Magdalena Brigger, Dr. Carla Pajak, and Dr. Suganya Reddy, who are coming to speak tonight. And I'm going to move over and let Magda take on the first part of the talk. Thanks, Magda.
Thanks, Helen. Good evening, everyone, and thanks for joining us. I guess just by way of introduction and a little bit of maybe advertising, I'll say that I'm a breast surgeon, but working in both public and private, I'm really proud to be part of the multidisciplinary clinic in both aspects of my life, which is actually really rare around the country. Multidisciplinary clinics where you have, a clinician like a surgeon or a breast physician, a radiologist, sonographers, and, the admin staff to support it all are quite expensive to run. So in public, bits of that are often outsourced or divorced from the same roof. So to have a sort of gold standard triple assessment one-stop shop all under one roof is really rare and a very good thing, which I'm hoping to impress upon you that actually referring to a breast clinic or a breast unit, if you've got the opportunity, is definitely the way to go. So my public life is at Counties Manukau, where we still have a one-stop shop triple assessment clinic. In counties and public, you cannot just refer for a mammogram. You have to refer to us as a clinic. And in private, we're all part of, as Helen said, Alivia Breast Institute, which connects with Alivia branches, and so we'll tell you more. So these are the topics that I've been given that you'll hear about over the next 15 minutes or so. And I've got to say, this is quite a lot to cover. So some of it I'll breeze through, but I'm hoping that you'll leave this 15 minutes with a very pragmatic approach to some of these topics. So we'll move through them in turn about understanding changes in perimenopause, assessing breast cancer risk, and guiding approach to screening and surveillance in primary care. With respect to the first topic, I mean, you all know probably better than I do the hormonal changes that occur during menopause. And of course, we see simplistic diagrams like this where estrogen, progesterone drops off. But we know that actually in reality, there's this perimenopausal period where all the hormones are actually haywire. And that's why, in my opinion, no two women will experience menopause and that perimenopausal period the same, is because that interaction with their breast tissue and their whole body actually is extremely variable. So it is quite hard to predict and make sense of and say what's normal, what's not. The sort of symptoms that occur in this period can be really variable. So changes in breast shape or size, sagging, ptosis, skin thinning can occur. So often women will present saying, they can see veins that are more prominent, things like that. As well as definitely tenderness, pain, areas of fullness or nodularity. So it can be all quite a mixed bag, and a lot of this can be normal, so hard for you to navigate. I think my main message to you is that if a symptom is purely internal, and that word internal, that's not a textbook word, that's just a word, a Magda word to help categorize. If the symptom is only something that the woman can feel, so tenderness, meaning, if you push, only she is feeling the pain, or pain that she's walking around with, discomfort, but no one else can appreciate it, those symptoms are likely to be okay, and they are fine to observe and don't necessarily need a whole bunch of investigation. Whereas everything else, if it's, skin thinning, maybe if you're sure that's looking at, that's fine to leave. Sagging ptosis, certainly if it's bilateral. But, everything else can be a bit hard to interpret, especially when you get into that kind of nodularity space or the fullness space, a change in consistency, which actually you can feel as well as your patient. So I think my rough rule of thumb is that if it is an internal symptom or clearly a bilateral sort of soft symptom, then you can observe that. You bring their screening up to date, so make sure they're not overdue for whatever their normal screening program is, and then, give them advice, return advice, like hopefully we all do in the breast care space, that, if something overt changes like a lump or nipple discharge or whatever skin change, they'll come back to you. But actually, pain, it's not a risk factor for breast cancer. If we find breast cancer with pain, it's usually with a lump as well, or, it's almost coincidental. So the yield of investigating breast pain is really, really low. And if the symptom is more overt, and so this is now the external symptom where you can see or feel it as well, then refer that. So, lump, rash, nipple retraction, all these things can be normal in the perimenopause, but I think you can set yourself up for failure if you are too confident in just, observing or discharging those kind of things. I think at the very least, if you're letting those things go, then see a patient in another 6 to 12 weeks or something and just check that they're not progressing. So then assessing risk and hence guiding screening surveillance goes a little bit like this. Um, you know how to assess risk. I'm sure we all learnt it at medical school. There's personal history factors, family history, some specific things, and then what I call soft risk factors. So by personal history, I really mean things that have happened to that woman in their lifetime already with respect to biopsies um, or breast disease. And also the new kid on the block here is what their breast density is. I think Sue will talk to this a little bit later. But breast density we know is actually an independent risk factor for some breast cancer, and we do use that information to a degree now. Family history, I'm not going to go through it, but I think you all have access to health pathways and things where your particular region will have some rubric for what pattern of degree of relatives you need. But certainly if someone's had a young relative or they've got a very special situation with male or Ashkenazi Jew or ovarian cancer, then that will usually trigger high-risk screening. And then by specific factors, I mean things like chest irradiation. So if they've had mantle radiotherapy, particularly in younger years, or if they're gene positive, then those are definitely reasons to refer for at least a high risk screen, if not other interventions. And then there's the soft risk factors. And so these are things that we've learnt in medical school. And some of them actually, I think, are becoming more and more evidence-based. Like I think the evidence-based around alcohol and breast cancer is increasing. Multiple CT scans and the radiation dose, there's probably a bit of evolving evidence there. But the reason why I call them soft risk factors is other than the advice that you give back to the patient to modify some of these, it's not really going to change our management. So if someone had early menopause, late menarche, we know that the number of estrous cycles does increase their risk, but meaningfully in the pragmatic world, it is not really going to change what you do to that person. So you don't have to spend a lot of time thinking about it, and Carla will talk to you separately about HRT. I guess I just want to highlight this past history group because when we're getting into diagnostic imaging or screening or surveillance, then it's really this past history group that we're referring to as surveillance, and I'll come to that again later, but just want to highlight that. Breast density, I think Sue will speak to, but I just wanted to mention again because I think it's really the thing that hopefully you know about is an evolving evidence-based space, that breast density is relevant to us not only because mammograms find it more difficult to make a picture through dense breast tissue and therefore are less reliable, but actually because, as I said, it is an independent risk factor for a slightly heightened breast risk. And so for those two reasons, women should be probably being screened more often and more thoroughly if they have a high breast density. Breast density is graded and should be reported now. There's a radiologist sort of statement from their college where it should be being reported, even if our clinics nationwide don't yet have the resource to deal with it. So you should be seeing in the reports that are coming through to you some sort of score from A to D, least dense to most dense. And there might be different language around that. Either it's a BI-RADS, Volpara density, where BI-RADS just relies on the eye of the radiologist to put people into a group, or there are software systems like the Volpara system that sort of calculate it in a IT sort of more scientific way. So regardless of how it is, you should be familiar with it, I guess. And the implications I've talked about already. So I guess in the primary care space, it's really important for you to know what you choose exactly when you've got the patient sitting in front of you. And I think my first step here is know what modalities are available in your area. This is a nationwide talk. The resource available through the nation really varies. We surgeons are on a chat group, and it's extraordinary what the variation is around the country. So know what's in your area. Again, Sue will go through these in more details, but just to cover them for the basic level, A two-dimensional mammogram is probably what we all grew up with in medical school, so literally an X-ray in two planes. And as my picture shows there with the arrows, it can be really subtle to pick up a breast cancer. The newer technology is 3D mammography, otherwise known as tomosynthesis, and this has technology very similar to CT scanning, where there's a sort of rotating X-ray system, and that enables slices to be computer generated through the breast and even some subtraction imaging to go on. So on the right side of my screen, that's actually the same patient that I just showed you in the 2D mammogram, where I think you can appreciate the spiculated mass is much easier to pick up compared to the 2D. Ultrasound is great, but very user dependent and can have lots of false positives. So mostly it's difficult to screen and start with ultrasound alone, because you can go down rabbit warrens of things that are hard to interpret. MRI is great, but also Sue will talk about it to you. But I guess from a practical point of view, can result in lots of false positives or things that need extra workup that create anxiety. The scan itself creates anxiety. If you're lucky with an abbreviated protocol, it's sort of 15 to 20 minutes, but otherwise the patient might be in there for 45 minutes in a noisy machine and prone with her breast tissue hanging away. So it's a tough scan, and it's not necessarily funded. Again, the new kid on the block is something called contrast enhanced mammography, and this is like a mammogram, but it has intravenous contrast given to the patient beforehand. And so because of the different blood flow that the breast pathology takes up, again, it will show up lesions much better. And this is a new space that I think we'll talk to you about in a minute. So then step number 2, when you're sitting in GP land, is to decide what scenario is in front of you. And probably if I have one take-home message and one thing that I really want to communicate to primary care, it is this step, because I grade breast referrals at the moment into Counties Manukau, and I kind of see this just done wrong in GP land relatively often. So what I think most of you are probably doing is just working out whether this is a diagnostic problem, that I have a new symptom, I need to diagnose it, or whether this is purely screening, so we all know what that is, no symptoms, and we're just doing a check, or whether it is that surveillance question that they've had something wrong and we had a look at the speech bubble before for what that something might be. This screening group might include the high-risk group, and there might be a different screening pathway, but in your head you should be still just asking yourself, is this truly screening, or am I trying to diagnose something? And then you've got, I think in most areas of the country, public or private providers, and like many areas of medicine, the sad reality is that the resource access that we have in both systems is different. So without hopefully bamboozling you, I just want to give you a feel for what the differences are. So here's my rubric. So we've got the different types of scenarios across the top, and then we've got public and private on the side. So if you've got a patient with a symptom and you're going down a diagnostic pathway, then most people will need a 3D mammogram and an ultrasound, and then they might need an MRI after that if the problem's not sort of fully characterized. But in I think all parts of the country, it is a 3D mammogram that they're given, and the only reason they wouldn't have it is if they were really young, or they just had a mammogram, within 6 months or something. It's quite often that I see GPs, have a patient presenting with a lump. They see that their screening is overdue, and they think that they will get the patient in faster to breast screen Aotearoa, and kind of say, okay, go for your screening mammogram, when, that 2D image could completely miss the problem and result in false reassurance. So I really want to highlight this point. If you're diagnosing something, then don't send them to breast screen Aotearoa. If you are just purely bringing them up to date with screening, so this might be the pain patient actually, where you don't have to diagnose pain. If it's purely an internal symptom, that's okay to just observe, but bring their screening up to date. And so in the public breast screen program, it is purely a 2D mammogram at the moment, and that's done for standardisation around the country. It's done because reading those 3D mammograms is very labour intensive, and so the country can't afford it. And also it's done because the data set, the IT kind of whatever it is, cloud space that's generated from those 3D mammograms is huge. So again, the country can't manage it. So I don't think there's any imminent changes here at the moment. Breast screen Aotearoa rely on 2D mammography. The imminent change that I'm sure you know is coming is that there'll be age extension up to 74, but I think the technology is with us for a few years yet. In private, we have a different approach. So if you go on the Breast Cancer Foundation website, they'll be telling women to screen from age 40 annually. Now we can debate whether that's overkill or not with, overdiagnosis and all that sort of stuff, but that is the message that is out there. And in terms of yield and picking up and not missing things, this is what most private patients really are wanting. And so in the private space, we screen everybody with 3D mammography, and then we add an ultrasound if they have a dense breast tissue, definitely category D and sometimes C as well. And then Sue will talk about, where the contrast enhanced mammography and MRI fit in and for some of those screening patients. In some parts of the country, those things are being trialled. I think we did a MRI pilot with Southern Cross in Auckland with Olivia Radiology, and contrast enhanced mammography, I think, is being trialled in Wellington as we speak. So these are things that you'll start to see around the country. In Canterbury, actually. My note is that in Canterbury, I've heard that the screening program is offering actually some supplemental screening 3D, sort of taking it onto their breast screen Aotearoa. So I'm not sure, you'll know if you work in Christchurch better than I whether that's eventuated, but it's my example really that you have to know what's happening in your area. I've had a little technology failure there. So high-risk screening, I don't know why my box hasn't disappeared, but high-risk screening and surveillance might be lumped in together in some services, and the differences go like this. Firstly, in the public system, for high-risk screening and surveillance, there is 3D mammography, but in the screening age group, to save money, most places will alternate with the 2D mammography provided by the breast screen service. In the surveillance group, if they've had cancer, then they're exited from the breast screen program for 5 years. So for 5 years, they'll have to have TOMO 3D mammography, but after that, they'll go to the same protocol as the high-risk screening group in most centres. In private, we have a lot more leeway in how we screen our high-risk groups, and that's where in some, particularly young women, for both high-risk screening and surveillance, we might be talking about MRI, and again, I'll leave Sue to go through some of that detail. I just want to say one word about Southern Cross, because officially on their policies, to get a 3D mammogram, your patient should have had a 2D mammogram or previously had breast cancer. So in reality, actually, they don't enforce this, but it's just interesting that, they're still, officially trying to save money as well. These boxes are really all over the show. Here we go. That's what you were meant to have seen. Sorry for a little technology blip. But I don't know if you want to take a screenshot of this, not because I need you to know every word, but just because I guess I'm trying to impress upon you that it is complex, it is different, and maybe try and kind of in your head fill out these boxes for what it is in your region. So I guess I'll wind up, but again, by way of advertising, say that, around the country, in the main centres in particular, there will be breast clinics that work in a multidisciplinary setting that do some of this decision making for you. And so, in both public and private, you can refer to the clinic and get advice about what the screening should be or what the particular line of investigation should be for your patient, rather than feel that you have to fill out a pad saying, mammogram or ultrasound, and really be committed to a choice that you then bear the responsibility of if it doesn't, quite work out well. Olivia Radiology rebranded from Mercy Radiology in the Auckland region. So if you're confused about that terminology, we used to be Mercy Breast Clinic. Now we're Olivia Breast Institute, but we're the same people under the same roof working with the local branches. So overall, my take-home messages to you go like this. With regards to menopausal changes, think about those kind of internal, external divisions. If the symptom is only internal, it's probably okay to watch. Bring their screening up to date. You're probably okay. And also if the symptom is subtly bilateral, so, some skin changes, redness is a common one because as the skin thins, it becomes a little bit more red because you see the little blood vessels through the now translucent dermis. So redness over the skin on both sides, that's fine to watch. See that woman in whatever, 4, 6, 10 weeks, whatever, and it's probably going to be okay and, evolving bilaterally and not a concern. If, however, there's a new external symptom, meaning that someone else can appreciate that, so it's, skin change, you can feel it, even if you think it's the most, soft, ridiculous lump, if you can feel it, I think we live in an age where you shouldn't be having a conversation with the patient trying to convince them that that lump is benign. You can do that in the teenage group, but not in this perimenopausal group. I think you need to refer that person for a diagnostic assessment. And then with the imaging, like I said, my take-home message is to make sure that you don't direct your patient with those kind of external symptoms to breast screen. That's not the place for them to go. Send them to your breast clinic or at least your, local radiology provider, but make sure that you're sending them for diagnostic imaging, not trying to masquerade them as a screening patient. And yeah, wherever possible, refer to a team because you'll just get so much more support, and then we'll bear the responsibility, if something's missed, which in the breast space is what we all, all fear, but it happens.
Thanks so much, Magda. That was brilliant. I'm going to pass to Carla now.
Thank you so much, Magda. That was a really great talk. My name's Carla Pajak. I'm also a breast surgeon. I have the good fortune of working with Magda and Sue at Alivia Breast Institute. I'm a breast endocrine and sarcoma surgeon, and I'm also at Auckland or ADHB. I'm going to be talking about MHT and breast cancer, which is an enormous topic, but I'm just going to try to condense it to sort of the salient points. I'll talk briefly about some definitions. We'll talk about breast cancer risks, some of which you've heard a bit about. And then I'll talk about sort of some of the big papers and the evidence around the relationship between MHT and breast cancer. And then I'll just leave you with my approach to this very complicated topic. As we all know, menopause is not just one thing. There's growing recognition of the perimenopause and postmenopausal period. And really, like that graph that Magda showed, you have wild fluctuations of hormones in the perimenopause period. And that's led to increasing recognition of the variant symptoms that causes for some women. And that's led to really a bit of a boom in development of approaches to and treating menopause. We know that menopause itself is defined as the period of greater than or equal to 12 consecutive months when you're amenorrheic. You have high FSH in that time, and you have consistently low estrogen in that time. Just to briefly recap about breast cancer, for many of you, may have been many years since you've looked at breast cancer specifically. We tend to divide breast cancer. The first big division is into hormone positive and hormone negative. Among the hormone positive cancers, these tend to be have the best prognosis. And then we further divide them depending on their HER2 positivity. HER2 enriched cancers that are hormone negative are going to be slightly more aggressive and they have a worse prognosis. And then finally, your triple negatives are hormone negative and HER2 negative, and they are quite aggressive and have the worst prognosis. I just highlight that because I'm going to be using terms like luminal A a little bit later on. MHT is available in a variety of different forms. What MHT is, again, could be its own talk, but just to briefly recap, there are four main groups of MHT. So there's estrogen, which is available topically. It can be given orally. It can be given transdermally, applied directly to the vagina. Estrogen and progesterone are available orally or in a patch. It's important to remember that estrogen alone as MHT can only be given to people who do not have a uterus. If you have an intact uterus, you can't be given unopposed estrogen. There's also synthetic steroids, and then there's newer combinations on the markets of giving estrogen with a selective estrogen receptor modifier to treat some of the symptoms of menopause and perimenopause. Just globally, for context, the scale of MHT is enormous. So if we broaden that out to the menopause-related market, which includes not just medical treatment, but also wellness, supplements, digital products, things like that, the global market is between $17 and $20 billion a year. So this is a not insignificant market. Of that, North America is the largest share. It's projected to grow about 5% a year. So if this is not something that you're encountering currently in your practice, It will probably be something that's coming. The study that I looked at for this projected over 1 billion women globally will reach menopause by 2025, which is now, and that equates to around 12% of the global population. So this is an enormous entity, and there is a lot of noise in this area and a lot of information being provided to women. If we look at MHT in New Zealand, around 5% of women aged 50 to 59 are using some form of MHT. That's most commonly European women. They're more likely than Maori, Pacific, or Asian women to be using it. If we look at Pharmac data of just dispensing of estrogen patches, this is a graph of that dispensing over time. So you can see there's been a pretty significant uptake in use of estrogen patches. So this is, I think, reflective of what's happened both in the media and culturally, but also reflecting changes in the data. That's the actual number of patches. If we then graph that with the number of users, you can see that the number of users is also going up, and that there's this increasing trend away from tablets and towards patches over time. And this is Pharmac data for New Zealand. If we talk a little bit about breast cancer risk, I think it's important when we're thinking about anything that's going to impact risk that we think about risk globally and all of the things that are impacting women's breast cancer risk. And we know a lot about breast cancer. We know a lot about its risk factors, and there are many, and their interplay is complex. A lot of them, though, reflect the woman's lifetime exposure to estrogen. And so it follows then that looking at exogenous sources of estrogen in MHT would be really important. But I think it's important to remember that this is actually only one slice of a very complicated pie. And as Magda alluded to, alcohol, for example, is another modifiable risk factor, and it has very significant impacts on breast cancer risk. This is data taken from the UK looking at the impact of alcohol on breast cancer, and I just really love this infographic. I've seen it a number of times. I think it's just a really powerful visual representation of the impact of alcohol on breast cancer risk. So I'm going to be sharing some of the data on MHT, and there's obviously a link between MHT and breast cancer risk, but I think it's important just to contextualize that there are other modifiable risk factors in patients' lives that are conferring not insignificant risk of breast cancer. So you can see as you increase the number of standard drinks per day, there is increasing breast cancers being attributed to that increase in alcohol. So MHT and breast cancer risk, really, we first started getting really worried about this, and I think this paper probably had the biggest impact on prescribing patterns and slowing down MHT use and being driven for fear of causing breast cancers. So this was the Women's Health Initiative. This was an RCT. It was a double-blind placebo. It was in 2002. They had 16,000 healthy postmenopausal women, and they randomized them to receive combined estrogen and progesterone MHT. The important thing to remember about this study was that it was actually designed to look at coronary heart disease, so it was not designed to look at breast cancer. They did an interim analysis, though, and found that they had an intolerable increased risk of breast cancer among patients who were given MHT, and so they stopped the trial early at 5 rather than 8 years. The hazard ratio was 1.26 in this study. And I think this study really sent shockwaves around, and people started really pulling away from prescribing MHT and had some fears around it. Hot on the heels of that study was the Million Women study, which was an observational cohort study of 1 million women in the UK. They were aged 50 to 64, and they grouped women into looking at their MHT use and then looking at things like breast cancer as an outcome. They found that among current users, the overall relative risk increase was 1.66 compared to never users, and that was for breast cancer incidence. Among estrogen only, that was slightly lower at 1.3, and the combined estrogen progesterone again was the highest risk category, which echoed what was seen in the Women's Health Initiative. Among women who are taking tibolone, which is a steroid, it was slightly lower at 1.45. This study has a lot of the problems that the more recent paper also has. They didn't control well for confounders such as BMI and alcohol, which I've just shown is really significant, and family history. They relied on self-reporting of HRT, and they also didn't look at screening and other health behaviors. So a little bit difficult to interpret, but this came out in The Lancet in 2003. And then we really saw rates of MHT prescription in response to these papers really dropping off. The pendulum has since swung back, as I've showed earlier. Now MHT use is making a big comeback and on the rise. And this is probably one of the more up-to-date papers that we have on MHT and breast cancer. So again, a cohort study. This was published in 2024, looking at 160,000 postmenopausal women. They had really good long follow-up. But I think it's important to note that this was done over a long period of time, and the prescribing patterns of MHT during that time would have changed significantly. They had almost 8,000 total breast cancers and 721 breast cancer-specific deaths. They, again, relied on self-reported MHT use, and they grouped people into combined estrogen, progesterone, estrogen only, and then categorized them as never, former, or current users. Around a quarter of women in this study were using MHT or had used MHT. 63% of them had never, and 11%, were former users. MHT users, when they just looked at their demographics, had higher alcohol consumption. They also had higher education levels. They were less likely to smoke, and they were more likely to have used OCP in the past. This is a very busy slide. I'll just summarize that paper, if you're interested in looking at it, has got an overwhelming number of tables. But what they really looked at is incidence, mortality, and survival. And not surprisingly, among people who used MHT, particularly the combination of estrogen and progesterone, there was an increased risk both in overall breast cancers, but particularly in the luminal A and B, which are the hormone-positive breast cancers. Here are the hazard ratios there for you. The subtype differences, there wasn't really a clear effect on the HER2-enriched or the triple-negative breast cancers, although they did think that the high-dose estrogen and low-dose progesterone increased the triple-negative breast cancer risk. A little bit difficult to interpret that because it doesn't make a lot of physiologic sense, so I take that with a little bit of a grain of salt. When they looked at mortality, they found that MHT use, in particular current combined estrogen and progesterone therapy, led to an increase in breast cancer-specific mortality, and that was particularly among luminal A-type breast cancers, so those hormone-sensitive breast cancers, which are the ones that we think of as having the best overall prognosis. They didn't see an association among the other subtypes. Survival, the flip side of that, there was no worse overall survival among MHT users, and possibly even a signal that there was some better survival if you're using MHT and you have a triple-negative breast cancer. Again, and the authors sort of caution against reading too much into that. The risk is related to dose and duration, so it goes up between 2 and 4% per year of estrogen progesterone therapy use, and longer use, more than 5 years, is going to double your risk, particularly if you have a luminal A-type breast cancer. The strength of this study, really large, population-based. They had really robust methodology. I think some of their problems, again, they're relying on self-reported MHT use. So you question accuracy when they do that. They didn't adjust for other health behaviors. So MHT users are probably more likely to be engaged in the healthcare system. and they had really small numbers in some of their subgroups. I might just skip through this a bit quickly, but really what happens in a lot of these papers and which muddies the water is this concept of a collider or index event. And that's when you've got multiple variables that are actually affecting what's happening. You can start drawing spurious relationships between them. And so I think MHT users are probably people who are more engaged in the healthcare system. In order to get MHT from your primary care provider, you can't be somebody who's at high risk of breast cancer, so there's probably been some pre-screening there. So it's a little bit difficult to draw straight causal lines between MHT use and breast cancer. These studies, though, they all do have a trend in increase in incidence and mortality of luminal A breast cancer. No effect on survival for others. It's important to note that estrogen alone has no significant association. That's sort of the same thing, sorry. Just a quick note about vaginal estrogen. Vaginal estrogen, I think, is used on its own topically is important to separate from MHT. And the take home from this is that it's safe to use. Generally, as an approach, you want to try other treatments first, lubricants, moisturizers, but you can use it, and you can use it even after an estrogen-positive breast cancer. It is safe to use while women are taking tamoxifen. There's a slightly higher risk if women are taking an aromatase inhibitor. When they look at serum levels of estrogen after starting vaginal estrogen therapy, there's either no increase or women get a little increase at first. That's probably because their mucosal membrane is friable and a bit fragile, and more estrogen's able to cross it. As it sort of regenerates from the topical estrogen, it becomes more robust and they stop absorbing as much. There's no evidence of increased breast cancer-specific mortality, and there's some weak studies that say no evidence of increased recurrence. So in conclusion, I think it's really important to think about MHT in the broader context. The other thing that I didn't get into is all of the benefits of MHT. And again, that's a bit fraught. There's now a lot of push that MHT is sort of the fountain of youth and that it's going to do a lot of things that aren't well substantiated by the literature. But it does offer significant improvement in quality of life, and it can address some other very serious medical issues like osteoporosis. Overall, breast cancer survival is improving. The dosages, the routes, the duration of MHT have all been refined. And really, I think we're probably never going to get a perfect study on this because it is so complicated. When did you start? Was it perimenopause? Was it postmenopause? How long? What route? What drug? So really, I think you have to take an individual approach, and this is how I would recommend you approach patients and MHT when they want to talk to you about their breast cancer risk. Start by thinking about what is their baseline breast cancer risk. Are there any modifiable risk factors that you can optimize? Do they have a high burden of non-modifiable risk factors that put them into a really high risk category? What are their symptoms? Are there any alternatives? What's the lowest possible dose and duration you can use? And also, I think it's really important to think about what that woman's engagement is with screening and other breast cancer treatments. And ultimately, it comes down to shared decision making between the two of you. It can get very complex. It can be very difficult. If this is something where women want to have a conversation about the risks specific to them, then a referral to a breast unit is a reasonable thing, either just for some advice to inform your discussion with her, or if you want us to have that discussion with these patients. Thank you.
Thanks, Carla. That was brilliant and really appreciate those take-home messages. I'm going to move on to Suganya.
Good evening, everyone. I'm just having a quick discussion on a very big topic, unfortunately, which is basically breast screening modalities. And I think Magda has already done a really good job introducing you to some of those modalities. I'm a radiologist, and as Magda has outlined, part of Alivia Radiology, we used to be called Mercy Radiology, and our biggest breast center is Alivia Breast Institute, which is in Epsom. So to start off with screening modalities, I've been given questions to answer in terms of what would be the biggest differences between 2D versus 3D or breast tomosynthesis. The biggest difference for us as radiologists is that the dense breast tissue can cause a significant masking effect. So you get a lot of fibroglandular tissue that can overlap a breast cancer with your standard 2D images, because the breast tissue is actually compressed, and as a result, it makes it more difficult for us to actually be able to see small cancers. With breast tomosynthesis, we have basically almost a 3D image of the breast, and how that's actually acquired is where the mammogram machine, the detector moves in an arc and basically gets images at different angles. Depending on which machine you're using, the angles are different between different vendors, and we managed to get high resolution 1 millimeter slice images, which actually reduces that masking effect that we see in a static 2D image for mammography. The other benefits of breast tomosynthesis includes the fact that it can separate a mass from the underlying tissue and allow us to look at margins of a lesion. So sometimes we'll see a mass and we can see that it's quite a regular margin, and then we know that's probably going to be a benign lesion. We do look at those in ultrasound. But if we see something that looks very irregular with the margins and looks very speculative, then we immediately know that that's probably going to be a malignant lesion. The third thing that tomosynthesis is really good for is that it actually enhances the distortion. So if you have a breast cancer, which is more infiltrating rather than an actual mass, it allows us to see the distortion. So a change from the regular pattern of the breast. And that allows us to know that there's probably a lesion that's infiltrating, and we need to actually have a look at that area on ultrasound as well. And for a lot of patients, what they have found with breast tomosynthesis is that with 2D imaging, we get what we call pseudotumors, where there's overlap of the breast tissue. And as a result, they actually can make it look like there's a cancer, but there isn't a cancer there. And so we tend to have to do extra images to actually clear that area and show that it's actually just summation of breast tissue. Whereas in 3D, we don't have that problem. So it has reduced recalls and reduced us having to do extra views. Sensitivity in terms of picking up invasive cancer specifically has been really great with tomosynthesis. There's studies which say up to 43%, which is the Malmo study that was done. As Magda mentioned, we have done a trial at Alivia, which was Mercy Radiology at the time, with Southern Cross, and we used tomosynthesis in all our patients in that trial, and we found that we had picked up at least 38% more breast cancers on breast tomosynthesis in comparison to just 2D imaging alone. So at Alivia, we use breast tomosynthesis for both screening and for diagnostics, and it is our standard mammogram. So I'm just going to play this image on the left-hand side, which is a breast tomosynthesis. And you'll see as we scroll through, this is a dense breast. And so you can see a lot of this white tissue, and you can imagine that we wouldn't be able to see a breast cancer quite easily. But as I scroll through the images, because they're high-resolution slices, you can actually see there's a cancer, there's a mass that we can see, which we wouldn't have seen if we had overlap of that tissue. And again, you can see the margins quite nicely. You can see that in this case, it's a speculated irregular margin, but also you can see calcification. And this is that separation I was saying, that you can actually see some separation between the adjacent fibroglandular stroma and the actual lesion. So this is the same patient with a 2D image, and the tumors here, as you can see on the tomosynthesis image. But there's a lot of overlap of that breast tissue, and we don't see the margins, and we can't separate the lesion very well. In this case, we still could identify that there was an abnormal node in the axilla, so that alerted us to that there would be something. On breast tomosynthesis, though, it's quite clear that this is a very malignant-looking lesion. This is the other view that we do, the CC view, where again on this 2D image you can't see margins and you can't separate the lesion very well from the breast tissue. But on the CC tomosynthesis image, which is this image here, we can see that quite well. So she had an ultrasound. She had a very malignant looking mass, which is hypoechoic on ultrasound, irregular margins, and she also had that lymph node, which on ultrasound shows a very thickened cortex. And actually, this is the fatty hilum, which gets distorted and gets replaced by that thickened cortex. So, what do we have as tools in our box for screening? And that would be quite a few different modalities. We've got breast tomosynthesis, as I've explained, screening breast ultrasound, and we've got, well, contrast enhanced mammography is, quite new to New Zealand, as Magda correctly pointed out. They're doing a trial at the moment in Wellington. We've been using abbreviated MRI for a good couple of years, at least, 5 to 6 years now. And for those that, haven't had any exposure to abbreviated MRI, I will be going through that in this talk. But in terms of modalities and sensitivity for cancer detection, this is actually quite an old study that was published in 2010 by Professor Cole, which shows the cancer detection rate in MRI was the highest. So that was 15 per 1,000 patients versus mammography on its own, which was 5 per 1,000 patients. But obviously, this is in the setting of 2D mammography, and also hasn't taken into consideration things like contrast-enhanced mammography or abbreviated MR. This was a full diagnostic MR study. So what is it about breast density that's important for us to note? The important thing for breast density is that a lot of patients come to us and say, "Oh, I've got a dense breast." But it's important to let them know that this is actually an imaging finding. So a dense breast is only something that we as radiologists can see on a mammogram or on an MRI. And we look at the imaging and decide how much of that breast actually has glandular tissue versus fatty breast tissue. So the fibroglandular tissue on a mammogram is all the white tissue we see, and the fatty breast tissue is the darker tissue that we see on a mammogram. So we assess that at Alivio using Volpara breast density, which is a software program, and every mammogram undergoes a breast density assessment. But this can also be done subjectively with a radiologist just looking at the mammogram. Once we look at the breast density, we look at the patient's risk factors, and then we decide whether this patient needs any supplementary screening, either with ultrasound or abbreviated MRI. So the difficulties with screening the dense breast is obviously, as Magda pointed out in her first talk, is the reduced sensitivity of a mammogram. And some studies suggest that that could be, in an extremely dense pattern, can be reduced to about 50% compared to a fatty breast pattern. High breast density also has an increased risk. And again, this was a publication that was in Radiographics in October 23, which showed that a density D can have at least 4 times increased risk compared to an extremely fatty density, which is a density A. So density D versus a density A. Higher breast density has also we've found that there's higher interval cancers, meaning that these are cancers that develop between mammograms. And usually when they do present to us, these are lesions that are actually palpable. So the idea of screening is that we want to find a cancer that's not palpable, because then it's small enough to have better treatment options and to have a better prognosis. So the interval cancers tend to present at a later stage of disease and at a higher stage of disease, whether that's with nodal involvement or more distant involvement. So this is an image where this is a fatty breast. You can see it's really dark, and a cancer which comes up white on a mammogram um, obviously stands out because of the dark tissue around it. So in a very fatty breast, we can easily see that as radiologists. But when we have a breast that's full of fibroglandular tissue, which comes up white on a mammogram, and a cancer is white against it, we obviously can't see it very well, so it's camouflaged. And you can see that in this here, where a density A is what we call a fatty breast, and that progresses on to a D, which is an extremely dense breast with lots of fibroglandular tissue. And if you can see this little star, which I'm not sure if projects very well on your screen, on a fatty breast, you can see that quite easily versus a dense breast where it's actually very poorly seen. Um, as discussed, we use Volpara density assessment. So we get a little scorecard like this, which basically tells us what density the patient is. And more so, it gives us an average volume breast density, which is a little percentage that we can include in risk tools like the Tazakuzak version 8 tool, which now does include breast density. And that was the tool that we actually used in our screening trial when we did the Southern Cross Mercy breast screening trial. So this was a study done quite a while ago as well, which basically showed that 39% of breast cancers in premenopausal women and 26% in postmenopausal women can be attributed to patients that have a BI-RADS C or BI-RADS D. So those are your two dense patterns, the C and D, and an A and B is what we call the non-dense pattern. When we did the pilot study, this is data from our pilot study that we did, and that showed that the highest number of invasive cancers were found in patients with dense breasts. And you can see that here, density C and D, the numbers were much higher than those with an A and B. So these are cancer patients. But in addition to that, what we could see was that if you look at the modalities, you will see that those patients with a C and D, their cancers were mainly picked up not on mammogram, but on either tomosynthesis, more so on ultrasound, and a contrast MRI. So again, that supports the idea of supplementary screening for these patients. When we used the TCH risk score, we had to actually adapt it for our setting in New Zealand, where high risk is considered to be greater than equal to 30%, whereas the TCA tool was actually devised to have high risk, and it's a UK-based tool. So high risk was greater than 20 to 25%. In the US, that's what they're using as well. And when we used it for 30%, we actually found that it wasn't very helpful because most of our cancer patients were actually within an average category rather than an intermediate or high risk category. So this is one of the patients that we had from our trial, which she came in for a screening mammogram. She had a TCH questionnaire, and that showed that she had a risk of greater than 30%. So we offered these patients that had a risk of greater than 30% an abbreviated contrast MRI for further detection of cancers. And this was read as a normal mammogram. And we actually even used tomosynthesis, and we still couldn't really see these lesions very well. So it was considered a normal mammogram, and she then went on to have the MRI, and this is what we call a post-contrast MIP image, which is a volume image that has been post-processed. And you can see in her left breast, she's had a total of 6 masses. So none of these we could see on this mammogram. There are a few cases like this from the pilot study, not all of them. As Magda showed, about 10% of patients will have an extreme breast density, and those are the patients that have the biggest reduction in sensitivity of their mammogram. In addition to actually finding a breast cancer that becomes difficult in a dense breast, the other thing that we found with our pilot study is that extent of disease was significantly more in patients that had a dense breast pattern. So, of all our patients, 42% of our total cohort of patients that we did in our study had an increased extent of disease with MRI. And of those patients that had an increased extent, 88% of those actually had a high breast density, so a density C or D, which again validates the need for a contrast study in those patients that had been diagnosed with a primary breast cancer, even on another modality like ultrasound. So this is a patient that had, again, a Volpara D, and she had what we call a normal mammogram, so no mammographic abnormality. But we decided to do an ultrasound because that's our protocol for our density D patients. We do supplementary ultrasound for screening presently, and we did find 2 masses on ultrasound in this patient that we didn't see on mammogram. And we then decided, because she was so dense and we found an abnormality, we should do an MRI. And the MRI then actually found at least 5 masses, which were called invasive cancers. And histology also showed that she had DCIS. So each of the masses on ultrasound measured a maximum of 15 millimeters together, whereas her disease extent had increased to at least 58 millimeters, because from this posterior aspect of the breast right to this anterior third of the breast, she had disease, which was quite occult on both mammogram and on ultrasound. But also, a lot of times we think, DCIS we can just see on mammogram because we'll see the calcification, microcalcification. But this just shows us that often we can get non-calcified DCIS, which will be occult on a mammogram as well. In terms of disadvantages, there are lots of disadvantages to doing, a contrast MRI study. And as Bacta said, patients don't like the claustrophobia, plus they have to lie prone. They have to be within a breast coil. So not really breasts hanging in a very bad position, but in a coil, which is quite makes the claustrophobia, I suppose, a bit worse. We do scan them from feet to head rather than from head downwards, so they're not within the gantry, and we try to reduce the claustrophobia in that regard. But obviously, MRI is a very costly study to do as a screening study, and it's not easily accessible. And also, it does have, although it picks up all the cancers, it also picks up all the benign lesions. And often it may be difficult for us, not with masses specifically. Sometimes we get to see the morphology on MR and kinetics. So when something enhances, we get to have a look at it in terms of margins, if it's a mass, and then we have a higher specificity for deciding whether that's a benign lesion or whether it's a malignant lesion. But in terms of non-mass enhancement, so those infiltrating cancers, those DCIS, those are the ones that can have an overlap with very benign disease like fibrocystic change. So it does result in a few more biopsies. Contrast enhanced mammography is a new tool, but has also been proven to have very good sensitivity and specificity in terms of cancer detection, especially in the dense patient. It has a different contrast injection. It has an iodine-based contrast, so the same contrast that we use for patients with CT. So it needs an intravenous cannulation, and we basically do a standard mammogram, and then you inject the iodine-based contrast, and you get an image, and then you subtract that from the mammogram image so that all the glandular tissue is removed, and you get an image with just the enhancing lesions. So the only difficulty about contrast-enhanced mammography is the fact that you have to have a setup where you can cannulate patients regularly and that you can check their renal function because it's an iodine-based contrast. So those are the difficulties in a screening setup to be able to do those. And I think a lot of centers will still have to figure out how they would go about doing that if we're going to have 10% of our population, our screening population, that's going to require this type of study. But I think it's been really good to actually look at if you're not keen on doing an ultrasound on the patient, and also if you don't have an MRI. Especially in Australia, a lot of the places that are out of big centers that don't have MRI access, and from even a surgical point of view, they use that as their tool for even diagnostics, so not just for screening. So all their breast cancer patients, to look for multifocal disease, will have a contrast-enhanced mammogram. It has the same disadvantages as the MRI. They both are contrast studies, so you will have benign lesions that do enhance as well. There wouldn't be an assessment of things like the nipple and the chest wall and axillary involvement like we do get with MRI, because we do have anatomical assessment on MRI. And obviously the data MRI has been around for a much longer time, but there's some really good studies now that have come out with contrast. So I just wanted to go back to our abbreviated protocol that we use at Alivia. We use it in combination with what we call a fast MRI technique. And this means that basically we can look at lesions that enhance soon after aortic enhancement. So a very good arterial enhancement that allows us to differentiate basically cancers from benign disease and from background enhancement. So fast MRI has increased our sensitivity and specificity compared to our use of just our standard protocol previously. The scan is with the fast MRI. We've managed to get it down to a 10-minute scan instead of our diagnostic protocol, which is a 40-minute scan. And because there's reduced scanning time, we have been able to reduce the costs of that. So, we've made the costs about half the price of a diagnostic protocol so that it will become more affordable for patients that want to screen, because currently there's no funding for patients besides the high-risk patients for MRI screening. And obviously the shorter scan for 10 minutes are much better tolerated for patients. So where is the world with screening in terms of dense patients? And this is the European Society of Breast Imaging, which came out with this recommendation following their dense trial, which was a 2-part trial, and showed that MRI had the highest number of cancers in dense patients, and also showed that by doing an MRI on a patient and doing a follow-up MRI, the interval cancer detection rate had reduced considerably because most of the cancers were found on the first MRI. So those were two strong points on that study, and so they came out with this recommendation that dense breast patients that have a density D, so that's the extreme breast density, should consider screening MRI every 4 years. This was a very good study done in the UK. It's the BRAID trial, which used contrast-enhanced mammography, MRI, and ultrasound, and found that 3 times more breast cancers were found in patients that were dense using a contrast study like contrast-enhanced MRI or contrast-enhanced mammography. ACR, which is the American College of Radiology, they recommend MRI for patients that are dense but have an average risk. We are not there yet. We don't have the resources for that. We are still doing ultrasound on those patients. Those patients that have an intermediate risk, that have an extreme dense pattern, we would consider doing an MRI on those patients, and obviously the high-risk patients, all of those patients get MRI screening. So to just fill you in on what we offer at Alivia for breast screening, all our patients are screened with tomosynthesis as standard mammogram. All of them get a breast density assessment. Presently, all the density Ds have supplementary screening ultrasound. And as Magda has pointed out, ultrasound does find a lot of benign lesions, so it does result in lots more biopsies, but it has found more cancers than mammography in some patients that have a density D. So just to go back to tomosynthesis with a density D, although if a cancer like the case I showed you is on the edge of the glandular tissue and the fatty tissue, then we can see those on a mammogram. But if the cancer is within the within the glandular tissue, away from the fatty tissue, it's really even hard on tomosynthesis, and it also depends. The density D category is a range, and obviously the higher the density in that category, the less sensitive the mammogram, even on tomosynthesis, will be. So those patients still need ultrasound, unfortunately, or a contrast study in our setting. And presently, as I said, everyone that just has an extreme breast density D is getting ultrasound. All those patients that are high risk are getting MRI, following our surgeons who see them and monitor them and refer them for MRI. And the patients that do have an extreme breast density with like other risk factors, so for instance, a family member that has had breast cancer below the age of 50, but it must be a first degree relative, or a combination of multiple first degree relatives that have had breast cancer below the age of 50, those patients, we are suggesting they can actually screen with an abbreviated MR every 3 years. Obviously, this is not funded presently in New Zealand, so there is a funding issue, and that is a discussion between the radiologist and the patient at the time of screening. So in terms of those patients that we had deemed high risk on the pilot study, those that had greater than 30% risk, those patients also we're suggesting that they have a screening MRI every 3 years. So where we are in terms of future screening trials, we want to look at AI programs and whether that helps us detect cancer, and especially those dense breasts that are difficult to find. We also want to trial looking at things like image risk, because of the fact that obviously the patient's density contributes quite significantly as a factor to breast cancer. And also we'd like to look at trialing CEM, and looking at how many more cancers we are able to pick up in comparison to using ultrasound on these patients. So this is our institute, Alivia Breast Institute, previously known as Mercy Breast Clinic, in Gilgit Road in Epsom, where we have the benefit of working with our surgeons in close proximity. So we basically have a discussion about patients, and if I need a surgical opinion, I can go next door and discuss it with Magda, or vice versa. If she needs a patient that she sees that needs to have a biopsy on the day, then we fit in those and we do those. So if there's a very good team that work together, we have breast nurses and our support workers with our mammographers as well. Our other branches, we have branches obviously in Botany, Franklin, North Care, Silverdale, and Westgate. And all of these patients that we do screening on, we do ultrasound guided procedures in these centers. But the patients that we need referral to our surgeons, we usually send them through to Alivia Breast Institute. And so thank you for listening to me.
Thanks so much, Sigania, and brilliant talks. I know there's been a wealth of work in the background from everyone answering most of the questions that have been coming through, so that is really appreciated, I know, by the audience. I think given the time limits we have and most of the questions that we've answered, if people would like to go through and read some of those answers, because there's a wealth of information coming through there as well. As a summary, I think we should go through each of the talks, and certainly there's a few things that I've pulled out as really big take-home messages. Magda discussing about deciding the scenario and the difference between diagnostic versus screening versus surveillance, and don't go to breast screen Aotearoa for diagnostics, and the consideration that is happening in private with screening from the age of 40 years as opposed to our nationwide screening system, which is sitting at the 45-year start mark. Carla, with regard to our menopause hormone therapy prescribing, that there is an increased incidence with luminal A breast cancer, especially with estrogen and progesterone therapy. And in our questions has come through that actually these studies have been done on pill therapy only, not progesterone provided by the Mirena. So I guess an important point to point out in the limitations of the studies that are showing these risks, that vaginal estrogen is safe to use. I think it was a good take home to have. And there are potential benefits seen across cardiovascular and bone and other health benefits, but we haven't really established those in entirety at the moment. Correct me if I'm wrong, Carla. And that there were three things to consider with regarding hormone therapy prescribing: the baseline risk, the severity of the menopausal symptoms, going for the lowest possible dose for the least amount of time, assessing your screening for those patients, and the shared decision making around that. So Gania, there's so much information in there, but I think pulling out for me the tomosynthesis identifying 38% more breast cancers compared to 2D alone is pretty confronting, I think, compared to how we have been screening in the past. So the opportunities that are there now with our new modalities, high density breasts having an increased risk compared to fatty breast density, that came through very strongly, and the extreme high density with alongside other risk factors, considering MRI screening for every 3 years is what you're offering within the Breast Institute, and I think is a really fantastic summary of the type of risk assessment and the approach to that. So I'm going to throw to the three of you very briefly for, I guess, any final comments, because those are the bits I've pulled out. I know you've been pulling through some of those questions as well. Is there anything else that any of you would like to add before we sign off for the evening?
I think in amongst all of this, we've got to acknowledge that there's a huge power of social media at the moment and non-evidence-based messages out there, and that relates to all of our talks, so, and some of the questions that came through about tomography and stuff. Unfortunately, some of these areas are sort of negotiating with the patient, and if we're trying to rationalize screening, there's papers coming out of Europe that are saying that for the very low risk woman, we should only be screening every 3 years with mammography, full stop, and really individualize those categories. But to go through the education of a population, let alone an individual, about things like that, and to tell a population that what used to be 2 yearly is going to for you just be safe 3 yearly is nigh on impossible, right? And so all these things, HRT, they'll be, your patient will know everything about HRT from social media compared to what you can educate them about evidence-based, and I'm sure you guys in primary care know that more than we do. So I think a lot of these areas are almost like a negotiation, but hopefully you can come from a particular angle, and then any negotiation that you make back towards an evidence base is a good thing.
Yeah, brilliant. Thanks, Magda. And I think you're right, that whole shared decision making, or the journey that you're going on with someone together, highlights that. Carla, anything from you? Can you wrap up?
I would just echo what Magda said. I think that I tried to get AI to quantify for me the number of influencers there are right now active in New Zealand in the menopause space. It couldn't do that, but it could give me a list of the top 100. So there is at least 100 that AI can pick up on. So I think exactly like Magda said, patients are being inundated with information about this. And so it's just really important that we come from a place of evidence and then just negotiate with them. I have a woman with breast cancer who had metastatic lymph nodes, who is on HRT, who flat out refused to stop her HRT, who has hormone-sensitive breast cancer, and she said she would rather die, than give it up. So I think it can be a very, very difficult conversation, and she's been on it for more than 10 years. So she's very, very high risk. She's on combined therapy, but she's not willing to, relinquish it. So, there's the standards, and then there's what you're able to negotiate with patients. I think we have to do our best in that space.
Yeah, that's really thoughtful. Thank you. And Sigania, what about you? I know there's questions that have come in while you were talking, and I think some of the information has come through in the previous answers, but I know that you've covered some of that in your talk.
Yeah, I just wanted to say that I know that dose has always been an issue because people look at a tomosynthesis like, as I said, like a little CT scan of the breast. But the dose, is really good to know that what we do is we actually get an image called a synthesized 2D image. So we're not radiating the patient again to actually get that synthesized image. And the total dose for tomosynthesis, therefore, is actually a very acceptable dose for a screening program. So, there's lots of studies that have been done on that. So I don't think that's something that, patients need to worry about. So I think, in terms of dose, I think that the tomosynthesis is an acceptable dose. It's far less than any other radiology procedure that you would have done. And to be done every year from the age of 40 is totally acceptable.
Brilliant. Thanks, team. Thanks, Sigania, Carla, and Magda, for sharing your expertise. And honestly, what incredible work answering those questions. I thought that's hugely appreciated. And thank you again for attending today and sharing everything with the audience.
Thanks.
Good night, everyone. Have a wonderful evening, and we'll see you at the next webinar.